Okay, so case control studies. The case control study, this is more practical but suffers from other disadvantages. Case control study, like I said, you have to pick the cases. Like if you look at gestational hypertension at week 24, you pick the women who had the gestational hypertension at week 24 and women who did not have the gestational hypertension at week 24. So those who had the gestational hypertension at week 24 becomes the cases, and those who did not have the gestational hypertension at week 24 becomes the control. I guess you understand now. Okay, then we look back at the risk factors that caused these women to have the gestational hypertension. What made the women develop gestational hypertension at week 24, whilst when they were pregnant at first trimester they didn't have any gestational hypertension? What were they doing? Were they not exercising well? Were they not eating well? Was their husband beating them? Were they not attending antenatal clinic frequently? And were they not on a good diet? Were they taking an unbalanced diet? So you look back at the risk factor. So the direction for case control study is a backward direction, and direction for longitudinal or prospective study is a forward direction. The direction for retrospective longitudinal study is a backward and a forward direction. So the case control study, this is more practical but suffers from other disadvantages. It is a retrospective study, yes. This means that, like a detective, you begin at the end with the disease and then work backwards to hunt for possible causes. In our example, you could identify a group of patients with brain cancer. This group of patients will be the cases in control group. Will be the cases. Then identify a control group who do not have the brain cancer. I guess you all understand. So let's look at this schematic diagram. So for retrospective case control study, okay, so where am I? So case control study. So let's look at retrospective case control study. So case control study is also a retrospective case control study, meaning that we begin, we have the exposed, not exposed, exposed, not exposed, like the 2x2 table I showed you. So this is the population. This is the population. Begin inquiry here and look back. So we select cases, those who have the disease, sample of controls who do not have the disease. So maybe at week 24, or maybe even at the end, at the delivery, you select the cases and the controls. Then you look back at the risk factors, what they were exposed to, and those who were not exposed to anything. What made them develop the condition, and what made these cases develop the condition, what made the controls also not to develop the condition. You look at it. So statistically, odds ratio is used to compute case control study, whereas in the longitudinal study we use relative risks. So this shows how many times more likely were the cases to have been exposed than the controls. So odds ratio is interpreted the same as relative risks. So it's the same interpretation, but case control we use odds ratio, whereas we use relative risks for longitudinal studies. Okay, so let's go and see another guy. So when you are calculating the odds ratio, we have the 2x2 table. We multiply A by D and C by B. Whereas the relative risks, that one, you look at A divided by A over B, then look at C divided by C over D, then use it incidence among controls, incidence among cases, incidence among controls. That's how we calculate the relative risks. But for odds ratio, you cross multiply A times D, C times B to calculate it. So for odds ratio, we have odds that a case was exposed is what? A A over C, then odds that a control was exposed is B over D. So when you calculate A over, so you end up getting, so when you do this calculation, the end result is that you end up getting A times D, C times. So whenever you get a odds ratio, just multiply. If you have 2 here, multiply by the 4 here. If you have 8 here, multiply, then you divide. So A over D, C over D, then you get this. So the odds ratio is sometimes called the cross product ratio. Why? Because you cross multiply A times D, C times B. Because the numerator is based on multiplying the value in cell A times the value in cell D, while the denominator is product of B and cell C. So number of persons exposed, so you go through this one, the time is going. Okay, so exposure and disease in a hypothetical population of 10,000 persons. So if you want to calculate the odds ratio, it will be 100 times 7920 divided by 80 times 1900, and that is what we are going to get the odds ratio. So odds ratio example, so let's use, so like I said, we have what, 100 times 7920, that is the odds ratio, 100 times 7920 divided by 1900 times 80 to get 5.2. Okay, so when, so we say another attractive feature is that the odds ratio can be calculated with data from a case control study, whereas neither a relative risk nor a rate ratio can be calculated. So if we are looking at relative risk, then you look at horizontal longitudinal study, but odds ratio is for only case control studies. But there are some papers that I have that I even use odds ratio for. You know, the odds ratio is very powerful. If you even have a longitudinal study, some of the time you even use odds ratio and no peer reviewer will complain about it. Then when the health outcome is uncommon, the odds ratio provides a reasonable approximation of the risk ratio. So the odds ratio is very, very important, especially if you have a rare condition, a condition that is not common. So let's see. So over here, this is the interpretation, the meaning of the odds ratio. If you have an odds ratio, this is the meaning. Odds ratio equal to 1 means that the cases and the controls, there is no statistical significant difference. Then odds ratio greater than 1 means that the exposure is positively related to the disease, meaning that the risk factor that is causing the disease, the risk factor is what is causing the disease. For instance, if you have lung cancer and the risk factor or the exposure is smoking, then if the odds ratio is greater than 1, if you have about 1.5 or 2 or 10 or 15, meaning that what is causing the lung cancer is the smoking. But if you have odds ratio less than 1, it means that the exposure is rather a protective association factor, meaning that if you are having lung cancer, if you are smoking, and we go and test and your odds ratio or your association with the disease is lower than 1, meaning that there is a protective effect, meaning that the smoking itself rather helps you not to get lung cancer. Let me take it again. Let me use sex as an example. Odds ratio equal to 1. So we are using men. Men, there are some rumors that if you have frequent sexual activity, it means that if you have frequent sexual activity, it means that your what do we call it? Frequent sexual activity means that you are not going to get prostate cancer. That is what people are saying. That's a hypothesis going around. So if the odds ratio for testing association between prostate cancer development, and sexual activity. So meaning that if the odds ratio is great is equal to 1, meaning that if you, whether you have sex, you marry 100 women and you have different sex, multiple sex, it will not do anything to your prostate specific antigen. So whether you are having sex or you are not having sex doesn't affect your prostate level. That is odds ratio is equal to 1. Then if the odds ratio, so 1 is always determined as the reference or the standard. If the odds ratio is greater than 1, meaning that if you don't have sex, you are going to get prostate cancer. So we are going to advise you that not having sex or multiple sex is not good, because you have to empty your prostate. You know, the prostatic urethra passes through the prostate. So when you are having sex, the prostatic urethra passes through the prostate gland. So when you are having sex, it empties your urethra, so you will not be having prostate cancer when you are 45 years going. So this shows that if you don't have sex, it is not good for your body, your prostate status. And this one is also saying that the odds ratio less than 1 will show that the exposure is negatively related to the disease, meaning that frequent having of sex will prevent you from getting prostate cancer. So sex is a protective factor against you acquiring prostate cancer when you are 45 years. That's why some of the men, they don't joke at all. At age 50, he has 5 girlfriends. I'm a pastor. I'm not advising you to go and do that. Okay, so experimental designs. So let's go to the experimental studies. So with the experimental studies, we have the randomized control trials and the quasi-experimental designs. So the randomized control trials is what I explained at the beginning of the lecture, that you do either a single blind or a double blinding. Single blind means that either the participants or the investigator does not know the results, or he doesn't even know the names of the people he's dealing with, doesn't know their results. You are blinded to their findings, or those participants don't even know the investigator. They don't even know what is happening, and they don't even know each other's results. Or if it is double blind, both the investigator and the respondents are blinded to each other's findings. We don't even know what is happening. And there is randomization, meaning that we pick at random. We don't say that I know this person, so because Mahama is distributing mobile phones, or the Akufo-Addo is distributing laptop, so my wife has to be part of this study. Then you select your wife favorably. No, for randomization, you pick at random. There's no who you know over here. Then the quasi-experimental designs. That one is a form of randomized control trials. But over here, we don't use randomization. Subjects are not randomized in this aspect. It's the same, it's an interventional study, but we don't randomize subjects over here. Okay, so we are left with just a few slides to finish. So in an experimental study, the investigator determines through a control process the exposure for each individual. That's a clinical trial or community trial, and then tracks the individuals or communities over time. So it's also a form of longitudinal study, but this one you have to introduce something to cause something, so that you now look for what you want to happen to the participants. It can be laboratory animals, it can be human beings. For example, in a clinical trial of a new vaccine, the investigator may randomly assign some of the participants to receive the new vaccine, while others receive a placebo. Whenever you hear a placebo, it's a pharmacological agent or drug which does not have the active ingredient. So placebo is what? Pharmacological agent which does not does not have the active ingredient. So I want to ask this question: who can give me the simplest example of a placebo? Are you with me? Who can give me a simplest example of a placebo? Hello? Who can give me a simple example of a placebo? Awini Abel. A placebo. David, what is a placebo? David, what is a placebo? A placebo is what? Anything without the active ingredient. Normal saline is a placebo. Clap for him, clap for him. Even common water is a placebo. It doesn't contain. So you can mute your mics and let me say something. Mute your mics. So you realize that some of the time you go to hospital, these psychological problems that people have, you go to hospital and they will just give you a placebo. You know, you go to hospital, you think you are sick. The doctor knows you are not sick. You say, no, I'm sick. You just go to the pharmacy and write a placebo for you. Go and take. There is nothing inside, but when you take it, you say, aha, I'm fine. Now doctor has given me medicine, so I am fine. My body is fine. And so there is nothing inside. But if it doesn't give you medicine, you say that I came to hospital and they didn't give me medicine. I'm sick. I will die. The doctor does not like me. The nurses do not like me. They don't like me. Aha, because I'm poor. Because I'm this. No. So they have to just give you placebo. So in a clinical trial of a new vaccine, the investigator may randomly assign some of the participants to receive the new vaccine, while others receive a placebo shot. The investigator then tracks all participants, observes who gets the disease that the new vaccine is intended to prevent, and compares the two groups, new vaccine plus placebo. In an experiment, by contrast, the researcher intervenes to change something. So, like I said, experimental studies or randomized control trials, we give patients an intervention and then observe to see what will happen. But in an observational study, you don't give patient anything. If you give the patient anything, you have flouted the ethical approval rules, and the IRB, Nabrongo Research, Noguchi, and they can deal with you if something happens to the patient. But you say you will not give them anything, you go and give them a placebo or something, and the person collapses and dies, you are in trouble. Experimental studies. In an experimental study the researcher intervenes to change. Oh, I've done here already. So example of experimental studies are applying or deceiving a law student with a beer to see whether lawyers argue better when drunk. Similar, in a trial to prevent onset of diabetes among high-risk individuals, investigators randomly assign enrollees to one or participants to one of these three groups: placebo, an anti-diabetic drug, or lifestyle intervention. At the end of the follow-up period, investigators found the lowest incidence of diabetes in the lifestyle intervention group, the next lowest in the anti-diabetic drug group, and the highest in the placebo group. So you want to determine the level of the incidence of incidence of diabetes, new cases of diabetes. So you get three groups: placebo group, anti-diabetic group, those who are on anti-diabetic medications, and those who are on lifestyle intervention. So at the end of the follow-up period, investigators found out that there was a lower incidence of diabetes in those who do lifestyle. They check their diet well, they don't eat anything, they don't eat meat, they don't eat fish, and they don't eat anything. If you don't eat meat, you don't eat fish, how will life be sweet to you? And these people will not get diabetes. Then followed by those who are having diabetes and they are on the anti-diabetic drug. But those who took the placebo without any active ingredient, they will have serious consequences of diabetes. Okay, so randomized control trial. So we get the population, people who meet selection criteria, example, have the disease being studied. So with the longitudinal study, we start with people or participants without the condition, then follow them until they develop the condition, but we will not intervene or interrupt by introducing anything in the study. Whereas in the randomized control trial, we start with people who are already having the condition, then we randomly allocate the people into intervention group and control group. Then the intervention group, we give them the treatment, we give them the drug that will cause them to have HIV or hypertension or diabetes or anemia or liver destruction or nephropathy, kidney problems. Then we give them our drug that will cure that condition. We do the same. The control group, we are not going to give them any intervention. We will not do anything to them because that's what the standard we are going to use to compare with the cases group. So we pick blood samples at time 1, and we pick information and blood sample also at time 2. Time 1 is the beginning of the study, that's the baseline, and time 2 is when serious condition or the outcome, the final response of the study, whether death or alive, disease or non-disease. So that's the outcome. So outcome is very important. Outcome, whenever you hear outcome in statistics, that's the disease status, whether you had the disease or didn't develop the disease. So outcome is also defined as disease status. So we find the difference in outcome score. So we say I1 minus I2 minus I1 minus the control C2 minus C1, and this shows the experimental change minus the change in the control group. So the experimental change minus change in the control group. Experimental change minus change in the control group. We are about finishing. So random allocation, meaning that there is no favoritism. Randomized control trial, we don't favor anybody and say, you, I'm giving you placebo, you, I'm giving you the drug. No, you give the drug, you blind everybody. You put them into groups, you blind them. So if you have 5 groups, you give group 1 the drug. If you have 2 groups, you give group 1. So what you normally do is that if you have like regional hospital, you have 10 okay, let's use laboratory animals. If you have 10 laboratory animals or 10 dogs that you are doing this experiment on, you are testing your drug. So 5 of you cover their eyes so that they don't see what is happening, or you do balloting. You write 1 2 3 1 2 1 2 1 2 1 2 1 2. So you have 2 groups. One is the control group and one is the study group. So you say you give it to the dogs. Whoever will pick, whoever will who is that? Abdullah. Abdullah. Oh, you can. I will forward this thing to you people. I will forward the. So you can leave. I will forward the recording. I'll forward the recording so I give it to the class. So goodbye. No, I'm saying I'll give you the recording, so don't worry. I'll give you the recording, so you mute yourself. We are finishing. We are almost finishing. So we have the group 1. Oh, Abdullah, mute your mic. Mute your mic. So we have 2 groups. We are finishing. So we have 2 groups, group 1 and group 2. 1 is those who having the problems, and 2 is the control. So we don't say that this is my friend, this is my sister, this is my... No. You either cover their eyes or you do balloting. So that you don't say this person should go and pick 1, this person should pick 2. No. You put them, you ballot. Whichever number you pick, you are in group 1. Those who are sick. And those who will be given drug to be sick. So that after you give you drug and you become well. So you ballot. Then number 2 is the control. Those who will not be given the drug, but they will be given a placebo. And those that you will not also cause. Then you have a 3rd group that you will not cause any condition in them, and you still give them a placebo. So it's random allocation. We don't show favoritism and say this is my brother, let me put him group 1, or this is my sister, let me put him group 2. So we have the experimental group and the control group. Then we take specimen at baseline. Then we take another specimen or measurement at the development of the condition or at the end of the study. Then, so this is how we go about it. Okay, so advantages and disadvantages. So let's look at cross-sectional study. Cross-sectional study examines the relationship between diseases or other health-related characteristics, other variables of interest as they exist in a defined population at one time. Exposure and outcomes both measured at the same time. Cross-sectional study is also called prevalence study, risk or diagnosing test accuracy. So we use it to diagnose test accuracy too. So advantages: it is very cheap and simple to conduct, ethically safe. You just draw sample, or if you do not draw sample, you just look at risk factors. The disadvantage of cross-sectional study is that it establishes association, like I told you at first. It doesn't infer causation. It doesn't say that drinking alcohol will cause you liver problem. It will say that alcohol is rather associated with liver problem. But whichever comes first, it will not show it. It will not say that, oh, this person killed this person. Because at the crime scene, the people you see there, you cannot say they are the cause. They are just associated with the crime. You have to now do the investigation to establish the cause. The cross-sectional study just tests for association. It doesn't infer causation or causal relationship or what caused the disease. There is recall bias, because when you are asking the participants questions, some of them do not even remember what you are asking them, and they don't know what they are saying. Some of them to social desirability bias. Social desirability bias means that the society wants you to behave in a specific way, so people don't even tell the truth. For instance, we all go to church. You go and fornicate with a woman and impregnate her. Then you pretend as if, oh, you have not done anything, and you'll be hiding it from your pastor, because if you go and tell them, they will say they have suspended you. So because of the demands of society, what society wants, most people are afraid to tell the truth. So we have social desirability bias. So they will not give you, the investigator, either the participant will not remember to give you the accurate response when you are interviewing them, or they will say things that society wants, society love, and they will not tell you the truth about their sickness or about their condition. Researchers bias. You, the researcher yourself, you may also be biased. Group sizes may be unequal, because some can take 500 cases and 200 controls. So that one also does not really tell or bring out the evidence or the strength of your study. Confounders may be unequally distributed. I'll be taking a course on confounders, so later I'll explain what confounders are when we get to confounding. Okay, so the cohort study too. What are the advantages and what are the disadvantages? Because I've already explained cohort studies. Cohort studies are ethically safe, like the cross-sectional studies. Cohort is the same as a follow-up study. Participants can be matched, meaning that when you are like the anemia or the gestational diabetes, you don't go and pick pregnant women and non-pregnant women. You pick pregnant women. Then you pick pregnant women who had the condition at gestational week of 24, and pregnant women who do not have the condition at gestational week of 24. So with the gestational week of 24 having the condition and those who don't have the condition at the gestational week of 24, we say what we have done here is what we call age matching. Age matching. Age matching. We can also sex matching. Sex matching. You say? Hello? Hello? Yes? What do mean, Saka? What's the problem? We are finishing, please. Let us finish in peace. We are just left with about 3 slides. Okay, Roger, off your mic and your video. Let's continue. So age matching, sex matching, occupation matching. So you say you don't go and pick lab people and go and pick nurses as an external control. You pick lab people and find out whether they are satisfied with their salaries or not. So you pick lab people who are of a particular experience, years of experience, and those with a lower years of experience. So you match according to what? Laboratory professionalism. Not go and match a lab person with a doctor or a nurse or a pharmacist. So we look at, so can establish timing and directionality of events. So ethically safe, we can match participants, we can establish timing and directionality of events. Yes, because cohort study is in the forward direction. Retrospective cohort study is in the backward direction. Eligibility criteria and outcome assessment can be standardized. Okay. Disadvantages. Controls may be difficult to identify. It's true. Exposure may be linked to a hidden confounder. There can be a confounder. I will teach on confounders, so when I teach you understand. Blinding is difficult. Randomized control is difficult to blind though. Master, when you are doing an experiment, some of the participants, you need their name so that you can follow them up proper, but it's not good to write their name in your questionnaire. For rare diseases, large sample sizes or long follow-up is necessary. And another difficult problem is that in follow-up, when there is a problem of losses to follow-up, and because of Boku War, you are doing a study in Boku, and you have to truncate the study because of all of them ran from the community. So you are lost to follow up. So advantages, case control studies too. Let's look at case control study advantages. Case control studies are quick and cheap, as fewer people needed than cross-sectional studies. So case control study, you don't need much people. Only feasible method for very rare disorders or those with long lag between exposure and outcome. So this one's diseases with rare disorders. You don't really know, it's not a common disease, and you use case control. Disadvantage of case control is that it relies on recall or records to determine exposure status. So you go and meet the cases, you ask them about their previous exposures. You understand? So that's the record. Do they remember what the food they took in last month or 3 months ago? Do they remember? They will tell you no. So this one can end up biasing the experiment. So it's a disadvantage if the cases can't even remember what happened to them. and if also the controls cannot remember what happened to them, or if they are even hiding something because of what society deems right or wrong. All this poses a challenge when you're conducting a case control study, and when you don't even have adequate records of exposures or exposure status of participants. For instance, go to the laboratory records are not there for the patient, delivery records are not there, records on diabetes are not there, OPD records are not there, intensive care unit records are not there. It becomes difficult. So that is what we call missing information, missing participant information. So all this, you have to remove these participants from the study, even though you have spent on them, but you have to disqualify them. So confounders, please let me just explain confounders so that when we start confounding, you understand. A confounder is like something that is associated with the exposure. It's a factor that is associated with both exposure and outcome of a study. So anything that is associated with both an exposure and outcome of a study is called a confounder. So a confounder like this: if you want to do an investigation on prostate cancer, you don't go and pick a woman and say you go and take a woman's blood. A woman becomes it will bias it. Okay, let me use this one. This one is much more clear. You are looking for hypertension. Then you go and recruit participants who are 20 years old, or they are not even up to 30 years old. Then you go and recruit participants also who are 45 years old going up, or you recruit between 10 years to 20 years. Then you recruit some 60 years, 70 years. Age becomes a confounder, because you know hypertension is associated with aging. So how can younger people have hypertension, even though some are having it when they are young? But you understand, it is found in the aged. So if you go and pick aged people and go and pick some people who are young and this, you will bias your experiment. So what you need to do is to select your experimental group. You have to assign an age categorization for them. The controls should be maybe above 45 years, and the cases also should be above 45 years. But if you pick controls who are lower than 45 years, cases also higher than 45 years or lower than 45 years, age becomes a confounder. So you have to be careful. Confounder is any lacking variable. We say confounder is any lacking or irrelevant variable that is associated with both exposures and outcome. So confounder is what? A confounder is any lacking variable associated with both an exposure and the outcome. So age becomes a confounder if you are looking at hypertension. Sex becomes a confounder if you are looking at prostate cancer, because women don't get prostate cancer. Their prostate is not even, it's just some small pointed something, skinny gland. So you don't consider it even as a prostate. So you understand? You are looking for the level of estrogen in women. And you recruit men as well. Sex becomes a confounder. So you are doing a study on hypertension. And the people, you didn't even record the intake of salt. So if you don't record the intake of salt, you are assessing for nutritional status. You didn't add salt as a predictor of hypertension. Then you haven't done anything on hypertension. So salt intake will now become, not taking salt will become what? A confounder, and it will spoil the results of the experiment. So selection of control group is difficult, because some of the time it's very expensive even to get the controls. You have to pay a lot of money to people. Potential bias, record selection, all these are important. So go and look at this, go through this table as well. Then advantages and disadvantages. Randomized control trials. This is the last lecture slide. So advantages is an unbiased distribution of confounded. This is the highest level of, if somebody does a study design, this is the highest of all the study. The findings out of this study is the best of all. The findings gotten here is the best. If they get a finding here, you cannot misconstrue the results, because this is the highest. So you can see we are on randomized control trials. Look at it here over here. This is the highest. If they say they do a randomized control trial and they say they've gotten HIV medication, you have to believe it, because it will work. But if somebody does a case control or case series or ecological studies, cross-sectional study, and say he has gotten a medication or a cure for HIV or Ebola or whatever, they have to even call the person and warn the person that, master, if you don't take care, we'll arrest you. Because what you are saying, you are just your study design does not merit. We cannot take firm conclusions and generalize your findings to the actual population or to the general population, because the weight of your evidence is very, very low. But with randomized control trials and meta-analysis and those things, the weight of their findings is very strong. So randomized control trial has unbiased distribution of confounders. So confounders like the age and others are distributed equally. So if there is distribution of confounders, like when you pick, if you distribute confounders well, like if you are looking at hypertension, you pick men with hypertension of age. If you are comparing women and men, so you pick the age. Women with hypertension, age greater than 40. Oh no, so let's just pick hypertensives, whether women or men. When you put them together, those with age greater than 45, those with age less than 45. Then looking at, so you see that the age is appropriately distributed. So you cannot have somebody who is among the hypertensives to be age 20 years. No, you can't be 20 years and be having hypertension, or even 10 years and be having hypertension, and you are among the hypertensive cohort. It's wrong. But if you are less than 20 years, if you are the control, you can be 20 years or even less and be part of the control, because you don't have the hypertension, because hypertension is associated with age. So you can see the age over here is uniformly distributed. There is unbiased in distribution of age as a confounder. So confounders are uniformly distributed. Blinding is more likely. Randomized control trial, I showed you how blinding is done. You hide information from the investigator or even the participants. So participants don't even know where their information is going, because their name will not be assigned. They will be assigned code numbers. So you are not going to use their name. Even the pathologist who will work on the blood sample, or the laboratory person who will help you to test for malaria and those things, they don't even know that this is a crucial sample you are working on. So both investigators and the participants are blinded. So we have double blind, randomized double blind control trial. Randomization facilitates statistical analysis. Like I said, randomization is what? Not showing favoritism, not handpicking people and giving them the best, but you just give to anybody who comes. You just distribute uniformly, equally, without showing any favor or anything, so that your experiment will not be biased. Okay, disadvantage. Randomized control trial is very expensive. You can use about 10 years, even 5 years. Very, very expensive. Ethical approval alone takes a long time. It's also very expensive, time consuming. Volunteers, you don't even get people to volunteer. You have gone to develop your own vaccine, and you want me, Ahinkra, to come, then you use me as a volunteer. Never. Even COVID-19, when they finish, people should come and they will inject them and see whether the drug will work. They didn't get people. So some researchers and scientists in France say they should bring the drug and come and use it on Africans. They don't want it to be used on Europeans. We Africans should rather be used and die. So there's a whole lot of ethical ramification problems. The ethical problems are too much and very expensive. The ethical approval board will not even give you ethical approval because it's quite complicated. That's why it takes about 13 years to develop just a drug. So class, without much ado, we come to the end of this lecture. Any questions whatsoever? Any questions? Hello? Any questions? Tell the rest that if they don't join, I'm not going to give any recording. So tell them right now to join. Any question? Tell the rest to come and ask their questions, so because I will not give any recording. They should go and read the slides. Any question? Yeah, thinking.